Good evening to you all. I am Brother Dr. Jeffrey Sterling, the Surgeon General for Alpha Phi Alpha Fraternity Incorporated. And as always, I want to begin by thanking our General President, Brother Dr. Willis Lonzo III, for providing this forum by which we can provide medical information and advice to the viewing audience. This evening, I am so pleased I'm actually kind of humored to have this topic, even though it's a serious topic. It just brings back memories of when I was a young one and various friends of mine would have their teeth pulled by tying a rope around it and then putting it on the doorknob and slamming the door shut. Yes, these things really happened. And I bring that up to point out the various advances in pediatric dentistry that have occurred. So we'll be talking about some of those. I don't think anyone will be talking about those methods of tooth extraction, but in any event, tonight's moderator filling in for our esteemed Deputy Surgeon General for Dental Health, Brother Dr. Langston Smith, is Brother Ryle A. Bell. Welcome, Brother Bell. Brother Dr. Bell is a professor emeritus in the College of Dentistry at Howard University. Brother Bell was duly initiated into Alpha Phi Alpha in 1977 through the Omicron Lambda Alpha chapter in Washington, D.C. He served Alpha well over the years, serving as historian, dean of intake, and many other capacities. And in 1985, he became a chartered member of the Omicron Eta Lambda chapter in Washington, D.C., serving as its president, chapter dean, and several other considerations. He is also a member of Mu Lambda chapter and served as its chapter dean, and just an all-around good guy, and obviously an emeritus and prominent physician in the DC area. Thank you so much for joining us in this capacity. Have a great show, and I'm looking forward to this fantastic panel that's been put together. I'll talk to you at the end of the show. Have a great one.
Thank you, Dr. Sterling. It's a great pleasure to sit in for my friend, Dr. Smith, who's the Associate Surgeon General, and have this great panel to interact with this evening. On behalf of our General President, Dr. Willis Lonzo III, our Board of Directors, our Surgeon General, Dr. Jeffrey Sterling, I welcome you to tonight's webinar. Our topic for this discussion is pediatric dentistry today. And for those who are not aware, pediatric dentistry involves the dental care of individuals who are not really considered to be adults. But they do have individuals with special needs very often as a part of the pediatric dentist practice. Our pediatric dentists are often thought of as children's dentists. However, they manage patients well into the teenage years, so they treat more than children in terms of their practical application. This evening, we have an accomplished panel of pediatric dentists who will share with us their knowledge and expertise on the treatment and management of this population of patients. We will learn something about the differences in dentition between them and adults and the modalities of treatment necessary for their care. It is my great pleasure to introduce to you our panelists, which I will do now in alphabetical order. Brother Dr. Christopher Chance is a board-certified pediatric dentist from Houston, Texas. He's a 2014 graduate of the University of Kentucky College of Dentistry, where he received his Doctor of Medicine in Dentistry degree. He completed a residency in pediatric dentistry in 2016 at the Case Western Medical Reserve University School of Dentistry, where he specialized in treating patients from infancy to adulthood, including those patients with special needs. In his spare time, he's a golfer. Don't know if he's good as Tiger Woods, but he's a golfer. And he's husband to Olivia, and together they have one daughter. His topic will cover the clinical needs of children's dental care. Our other panelist, Dr. Tanisha Francis, is also a board-certified pediatric dentist, graduate of the University of Medical and Dental School, New Jersey of 2000, where she received her Doctor of Dental Medicine degree. She then completed a general practice residency at the Bronx Lebanon Hospital in New York City before undergoing training in a pediatric dentistry fellowship and specialty certification in pediatric dentistry at the Children's Hospital of Philadelphia. She has served on faculty at Newark's Beth Israel Medical Center and conducted a private practice in New Jersey for some time. Presently, now she maintains a private practice in Brooklyn, New York. She volunteers for dental services to meet the needs of children locally and has traveled to China as a delegate ambassador for the People to People program. She's also a member of one of our illustrious Divine Nine, being a member of Alpha Kappa sorority. Her topic will discuss dental materials used in the treatment of pediatric patients. Brother Dr. Rodney Jackson is also a board certified pediatric dentist involved in private practice in Lexington, Kentucky. He received his doctorate in dental medicine from the University of Kentucky College of Medicine in 2001. He then attended the Chandler Medical Center in Lexington, Kentucky, where he completed his residency in pediatric dentistry in 2003. He will cover current treatment modalities in pediatric dentistry. Welcome to you all. As you can see, we have quite a distinguished group of panelists here this evening. And before I start, a brief note of housekeeping. Please mute your devices unless you're speaking. And then after all the presenters have completed their topics, each one will return for a brief 1-minute wrap-up to capsulize the presentation and maybe tell us something that they don't want us to forget about their presentation. Following that, we'll entertain questions placed in the comment section as time permits. So now we will begin with Brother Dr. Christopher Chance. Chris?
Thank you, Dr. Bell. I do want to make one correction on the bio. My wife is Dr. Courtney Jacobs Chance, and Olivia is our daughter.
Okay.
But, no worries. I was initiated through Epsilon Chi chapter Alpha Phi Alpha Fraternity Incorporated at University of Kentucky in fall 2008. I want to thank you all for coming. I want to thank Dr. Sterling, Dr. Bell for allowing us to be a part of this discussion. And I'm very honored to be just a member of this panel with such illustrious doctors such as Dr. Jackson and Dr. Francis. But I do want to talk a little bit about some of the things that I'm seeing in my practice here in Houston, and in ways that COVID has kind of affected some of our treatments that I'm seeing that we're needing to do, and the importance of coming to the dentist early for your children, bring your children early, and the importance of keeping their teeth as pristine as possible. Similar that was mentioned earlier by Dr. Bell in regards to pediatric dentistry, it is our job to help children and their parents understand the importance of prevention and care of their baby teeth and their dentition as a young age, because that will help them become more astute individuals in regards to their health when they become older. I remember when I was in dental school, and in dental school we treat mostly adults, and a good amount of them had really have done detrimental jobs on their teeth in regards to keeping them clean, and they needed a lot of work. And I would always ask them, what took you so long from coming in, or why is it to this point? And they almost always go back to when they were a child, when they either had a dentist that their time at the dentist wasn't enjoyable. And so that's what we're here to change. And I'm going to talk a little bit about the importance of coming to dentists and coming to the dentist early. Focusing on cavities and dental disease. Cavities are basically holes in your teeth that are caused by bacteria that process the food that we eat and create acid, which enough acid can create a hole. And so cavities are the most common chronic disease in children. About 40% of children by kindergarten have cavities. And in regards to school-age children, about 51 million school hours are lost every year due to dental-related illness. So one of the biggest things I can drive home is it's not just baby teeth. Just because you're going to get another set or get another adult version of the teeth, that those baby teeth are going to fall out, it doesn't mean that we don't need to keep them clean. We don't need to take care of them. As I mentioned before, it is going to help them a long way throughout adolescence and adulthood to be able to know how to take care of their teeth. So that's all they know. Now, dental cavities basically are absolutely preventable, and a couple different ways to prevent cavities. First, brushing teeth when they first get them. So when that first little tooth comes in around 6 months, sometimes it can be later. When that first little tooth comes in, it can get a cavity on it. The same amount of bacteria that can arise when they're much older can also arise when they're just getting their first tooth. So it is important to keep the teeth very, very clean. And then also when that first tooth comes in, to go to the dentist, seek the pediatric dentist so we can better have a plan for healthy and prevention measures for your child. Now, as a young child, some of the bacteria that occur in their mouth are very new. So they've never had a cavity. They don't have that type of bacteria that can make cavities go faster, but potentially we as adults have. So as an example, let's say I had an ice cream cone, and let's just say I've had a cavity before, and I eat an ice cream cone and I want to share it with my daughter. I have a spoon and I put it in my mouth, and then I take that same spoon and put in the ice cream and then give it to my daughter. Then the bacteria that I have that have caused cavities in the past are now introduced to my daughter. So then it allows for a rapid succession of events in regards to cavities forming a little bit quicker than they would had I not shared that ice cream. So there's little things that can help, other than the typical brushing in the morning, right? 2 minutes in the morning, 2 minutes at night, flossing at night. If there are two teeth that are touching, then you want to floss between them because bacteria can grow in there very easily. Also, another thing to prevent cavities is that for young children, please try not to have them go to sleep with a bottle of milk, bottle of juice, what have you, because as they go to sleep, we create less saliva when we're sleeping. So there's really not anything that's going to wash away that milk or that juice. So it sits on their teeth all night and allows for cavities to form very, very easily. In our practice, we're seeing young kids, as young as a year old, 18 months old, having cavities already. And so, and it makes it difficult with having to treat cavities on children that young. So, and Dr. Jackson may go into some of the ways to treat kids at young ages, but prevention is the name of the game, because we don't want to have to utilize some of these interventions, even though they're safe and we exercise all proper precautions. We want to prevent having to utilize them if we absolutely can. Also, if we're, let's say, breastfeeding, right? So if they're feeding at night, you want to at least wipe their teeth before having them go back to bed. Same thing with the bottle. You just want them to have clean teeth before they go to sleep, so that we don't allow for the bacteria to grow. I mentioned before, but bringing your child to the dentist when they get their first tooth, no later than their first birthday. That's very important, because we can lay out a game plan on how to keep your child's teeth very clean. Also, we're able to see whether or not there are, underlying diseases that could be manifesting themselves as certain lesions, certain marks, or certain just manifestations in their mouth, just red spots or anything like that. That could be something a little bit more serious. We are also able to determine at a young age, whether or not they have any mobility issues, let's say with their tongue. If they have an issue, let's say they're tongue tied, which is actually a thing, where it may have even arose much earlier in life. Let's say they had an issue with latching on while trying to breastfeed. Things like that we can see way early in advance. So that's one of the biggest things I can drive home, is that we definitely need to have our children in the dentist's office early, so we can discuss what's going on and to allow for them to have a successful rest of their years in regards to positive experiences at the dentist, one, but also a healthy game plan. And drinking plenty of water. What we're basically doing with cleaning teeth or preventing cavities, to me, are two things. We're taking away the bacteria that causes cavities, and the food that the bacteria love to eat by brushing and flossing. And we're decreasing the how we feed these bacteria by drinking plenty of water throughout the day, especially between meals. If we're doing juice, thinning it out with water, right? Cutting it, half and half, juice, water. If less is even better, and trying to keep those types of juices during meal times, breakfast, lunch, dinner, and not allowing them to drink juice and soda and everything like that throughout the day. And then having healthier foods, not snack foods, chips, crackers, gummies, which also includes gummy vitamins. Be careful with those. And so basically we're just trying to have a nice, healthy, clean diet as well, which will help them in other things like overall general health. Now, at my office, what we're seeing is I'll say COVID has presented a kind of a unique experience. So I opened my office September of 2020. So about 6 months after COVID really kind of, caused the shutdown and what have you. And we're seeing that there was a certain period of time where schools were out and the students were doing remote learning. And for that remote learning, and we're doing it via Zoom or what have you, you may have access to the pantry, right? You're at home, so you may have access to the pantry, you may have access to the refrigerator. So kids may have been grazing throughout the day, which they otherwise wouldn't be because they would be at school. And so we're seeing a manifestation of more cavities in some kids of older ages, but also there are a population of children who have not been to the dentist since COVID, right? So as you can imagine, some individuals are, nervous about getting out into the world, nervous about going to the dentist's office, whether or not they could contract COVID, which is, it's absolutely extremely rare for that to occur because of all of our infection control practices and everything that we do and that we have been doing actually for decades. The use of masks, use of just how we clean and how we keep our offices pristine. It's absolutely extremely rare for that to occur. But we're seeing now patients whose parents are more comfortable coming out into the world. And so they're coming in with more cavities and also potentially more apprehension, right? They may not have been to the dentist for 2.5, 3 years. We are not able to build that kind of rapport, keeping that rapport over that time. Or this is the first time, 5, 6-year-old, 7-year-old child, first time ever going to the dentist. So you can imagine they could be quite a bit nervous. And so some of the things that we're seeing, we're combining a lot of increase in the amount of decay that we're seeing, but also the increased amount of apprehensive at the dentist office. And so that may lead us to do more treatment, having to need forms of sedation or forms of treatment while a child is asleep, which is a very safe practice. But I've seen when I'm not in my office, I'm actually working at an outpatient surgery center, and we do that quite a bit. So I have seen an uptick in that, which is a segue into our next topic with Dr. Rodney Jackson, who's going to talk a little bit more about treatment modalities and how we're able to do treatment using methods such like sedation.
Good evening, brothers. My name is Rodney Jackson. I pledged Alpha Phi Alpha Fraternity Incorporated Alpha Pi chapter at the University of Louisville in the spring of 1995. And I'm here to talk about the different treatment modalities that we use to treat our pediatric patients. So the way that we determine what treatment we're going to use is based upon 3 things in my opinion. First is the patient's behavior. The second is certain medical conditions. And the third thing is the amount of work that we're going to be doing. So whenever I have a new patient or any patient that comes into my office, my staff is trained to immediately start to assess the patient's behavioral status, so we can kind of develop a game plan with ourselves and with the patient's parents to determine the best way of getting the work accomplished. So if a patient comes into the office and they're really apprehensive or nervous, we automatically know that if, when they're coming back for x-rays, they're crying, they're getting their teeth cleaned, they're crying, the likelihood of them allowing me and my staff to have them lay down, put laughing gas on their face, or maybe giving them an injection is relatively slim to none. So we automatically know what script we're going to be following with the patient, with the parents. So, you know, we get a patient in, say, for instance, they have a cavity on their tooth that needs to be addressed. We talk to the parent, we give them the different options. Well, I'll start with the most minimal and then go to the most drastic. So first thing we would do, we just tell the parents we can just do a simple filling. You know, sometimes the fillings don't require anesthesia, so we don't have to numb the teeth if we caught it early enough. And like Dr. Chan said, that's one of the important things of getting into the office sooner on a regular basis, is because a lot of the problems that we see, if we can catch them at the early stages before they're progressed, we can treat that more appropriately at a earlier stage and make it be much less invasive. So if we can fix it without having to anesthetize or numb the patient, we'll do it that way. Oftentimes it requires an injection in the mouth to numb that particular area of the mouth in which we see the cavity. Parents give us guidance as to whether or not they think the patients are going to tolerate that well or not. I always defer to the parents because ultimately they are the decision makers for their child's well-being. But I always gauge it by asking the parents how they do at the pediatrician when they get injections. Like when they get their immunizations. If they say that the patients just sit there, they're unfazed, then I think they'd be a good candidate for just a simple injection. If they say the kids are kicking and screaming, then I kind of go down the other avenues to which we can offer the treatment. So first one is just a simple injection to numb the area of the mouth that we're going to work on. If the parents don't think that they'd be a good candidate for that, they're a little bit anxious or nervous, they need something to calm them down. The next step that we go to is laughing gas. Nitrous oxide is what we call it. Laughing gas is what most people know it as. Laughing gas is a relatively harmless gas that the patients breathe in through their nose. It causes a sense of calmness. It doesn't make the kids pass out. Some kids will giggle, but the vast majority of kids just kind of have a dazed look in their eyes. It just mellows them out and lets them be less aware of what's going on in their surroundings to enable us to be able to do the work appropriately. If a patient is really nervous during the cleaning, the likelihood of them letting us lay them in the back and put the nitrous mask on their nose, again, is slim to none. So we go to the next step in our armamentarium that we use to treat patients, that being sedation. So I personally love to do sedations. We did quite a few of them in residency. And when I opened up my practice, I always knew I wanted that to be an important part of my practice because it's a good medium step in the treatment of patients. So sedation involves different types of sedation. You can do intramuscular sedations where you give an injection in their arm. I do a couple of those, but not very often. There's a IV sedation where you start an actual IV and you give medications through the IV. I used to do those quite a bit, but I don't hardly do them at all anymore. And then my personal favorite is what we call the oral sedation or conscious sedation. That involves the patients coming in, drinking a liquid medication that makes them go to sleep. The types of medicine that I use a combination of 3 different medications. I use Valium, I use Demerol, and I use hydroxyzine, which is kind of like a Benadryl. So the combination of those 3 medications, my personal regimen is I give it to them. They go out to the waiting room. They wait about an hour to an hour and 15 minutes before my staff is instructed to bring them back. Our front desk is constantly monitoring them, determining whether or not how effective the sedation is going to be. Once the patients are starting to feel it after an hour and 15 minutes, some will fall asleep within 10, 15 minutes. Some will just sit and watch television. Some just get that blind daze in their eyes. We still wait at least an hour before we bring them back, because if I bring them back too soon, sometimes the patients will be aroused when we bring them back, and it will be considered a failed sedation because they're not as sedated as I ideally like them to be. So we always wait at least an hour before we bring them back. Once they're back, we supplement the sedative effect with a little bit of laughing gas to help take any edge that they may still have, even though they're in an altered state of consciousness from the sedation. And then we're able to do the work. Surprisingly, most kids do really well with sedation. You can do a couple of teeth, like 2 to 3. The most I've ever done on a sedation is 15 teeth on one patient. It was more like a general anesthesia case, but the parents had private insurance and they didn't want to pay to go to the OR, and they told me to do as much as I could. Sedations are dictated based on, it's determined on the patient's behavior again, but also the amount of work. Typically, if I have a patient that's going to require more than one sedation, I would recommend to the parents that they go the general anesthesia route, primarily because, there are risks involved whenever you sedate a patient, a child especially. They're very reactive to different things. Their airways are more reactive, more so than adults. So if it's going to require possibly 2 sedations, I advise the parents to go the OR route, just because I know personally I wouldn't want my child to go through 2 different procedures and go through that risk twice, as opposed to just getting the work done at once. So typically when the sedation is done, we finish with the patient. We turn their laughing gas down. We slowly let them wake up. We have a certain list of discharge criteria that we want the patients to be able to meet before we discharge them home, because we want to make sure that they're leaving in a safe and stable environment. So we want to make sure that their heart rate is stable, their blood pressure is as close to, if not better than it was when they came in for the procedure, because we always do preoperative vitals. We want to make sure that the patients are able to sit up. We also want to make sure that they're able to talk and have a decent conversation. They might not be able to have a conversation as good as if they weren't in that sedated state, but we want to make sure that they can converse and that their mental status is up to par. We also want to make sure when we stand them up that they're able to walk with us, providing minimal assistance. So I'll always hold their hand, and if they're tilting over, falling, like feeling like they're dizzy and can't ambulate or walk on their own, then we tell the parents we want to keep them and monitor them for a little bit until their status is to the point to where we think it's safe for the parents to take them home. Like I said earlier, the next step beyond sedation is what we call general anesthesia. So general anesthesia is handled a variety of different ways. At my practice, we use 2 different treatment methods of general anesthesia. The first method that we use, I go to a surgery center, much like Dr. Chan said previously. I go to a local hospital here in town that has a surgery center attached to it. When we go to the surgery center, it's a medical physician that's providing the care and the anesthesia services. I do the dental work. The anesthesia team at the hospital does their portion. So, and that involves general anesthesia. So when we go to the OR, since we're working in the mouth, most oftentimes the patients are intubated, just like you see on television. They put the tube in your mouth and the machine is breathing for you. But since we're working in the mouth, the anesthesiologist put the breathing tube through their nose actually and bypasses the mouth, so that we have open access to do whatever we need to do in the oral cavity. The other type of OR that I use is there's a anesthesia group that goes to different offices. Across the hall from my office, I opened up an OR surgery suite where they come to provide the anesthesia services. When they come, they have a paramedic with them, they have an anesthesiologist, and they have a registered nurse. So all of the emergency personnel are there in case an emergency arises. But it really depends on what the parents' safety and their parents' safety track is, or what their preference is as to the way that we do the work. A lot of times I feel like a patient can be sedated, but if they have certain medical conditions like asthma, I prefer not to do a sedation in the office. I definitely refer those patients to the OR, just because it's a more controlled environment. I'm not risking them having an asthma attack in the middle of my procedures. Like Dr. Chan said, we see quite a bit of special needs patients in our practices as well. I have a lot of autistic patients in my office. I have a lot of Down syndrome patients in my office. I have several cerebral palsy patients in my patients, and it gets to the point to where sometimes it's just easier and much less stressful on the patients for us to be able to take them to a more controlled environment, i.e. a surgery center or a hospital, and do the work, as opposed to putting them through the stress of coming into the office and having to us try to do the work on them in the office with them not being able to be the most cooperative. So now that I've talked to you about the different types of treatment modalities in which we get the dental work done, Dr. Francis, my friend, she's going to be talking about the different materials that we use in pediatric dentistry.
Hello, my name is Dr. Francis. I would like to thank Dr. Sterling, Dr. Bell, Dr. Chance, and Dr. Jackson for laying down the foundation and explaining everything, and for also giving me the opportunity and the platform to be here this evening. I am from Howard University. I did pledge Alpha Chapter in '94 for AKA, so I am representing my sorority here this evening. So to step into the platform that I'm going to go into, thank you, Dr. Jackson, for transitioning everything over here, going into dental materials and the different type of treatment plans. So to bring patients into the office, normally what causes patients to really come in and what parents really tend to be faithful to are their 6 months cleanings and checkups. But what I really want parents to know what's really important when they're coming in is really not so much, well, it is important to get the cleaning, but from my perspective, what's really important is that exam and us checking to see if there's really any dental cavities, which Dr. Chance did explain what dental caries are, when the cavities are. Now, once the cavities do exist, then we're going to talk about the treatment plan, the dental materials that we use. Now, what we do have is if it's a cavity and it doesn't go into the nerve, and what Dr. Chance was mentioning was that it's a hole in the tooth, there's something that we can do that's called fillings. Now, filling can either be white, which is called a composite, or it can be silver, which is an amalgam. Now, a lot of parents sometimes get concerned about the aesthetic of the amalgam. Now, research has shown that amalgam is stronger, but the composite is prettier. Normally, when I'm trying to determine if I'm going to use a composite or amalgam, I do a caries risk assessment, meaning, is this child a patient that has a lot of caries? Does this child come in frequent to the dentist? Do they honor their 6 months appointments? If a child has a lot of cavities, sometimes I will explain to the parent that this patient may be better to get an amalgam because I know the amalgam is stronger and it doesn't leak as much. Because no matter what, I try to explain that when you eat and drink, no matter what the material is, it's going to shrink and it's going to expand. And sometimes they can cause leakage. So the ideal for us to have a success in a filling is that we don't want it to fail. We don't want the filling to fall out. So we just need the filling to last long enough till the tooth falls out. Now, some parents would say, oh, well, the tooth is going to fall out soon. Not necessarily true, because what I try to explain to the parents is that when you're talking about molars in the back, these are molars that you eat with more than once a day, more than twice a day. And as children get older, like when they go to first grade, second grade, you're not always there with them. And they're trading foods off. You're going to tell them don't eat things that are sticky. In my practice, some of my patients have nannies. They are not always compliant to what the parents say they should be eating. They go away to sleepovers. They are trading off candies. Parents don't realize that they're having candy. And what happens is that now they're eating things that the parents can no longer control. So if you know that you do not have a compliant child and they're high caries risk, you may want to reassess what type of filling you're going to put in. The idea for me is not to be doing fillings multiple times. Now, the white filling is very pretty and it can go in the back with the molars, but I do not want it to leak. So what I've seen, and I do explain to parents, is that sometimes I see like little children, like 2 or 3 years old, get these white fillings, but the molars do not fall out to age 11 or 12. So if I know I have a child that is getting decay at age 2, 3, 4 in their molars, and I'm explaining to the parent, this is a high caries risk child. This is a high caries risk patient. We may want to consider which materials we're using. So those are for fillings. Now, if I have a child that may only have 1 or 2 cavities, I'm okay with the composite. But I feel like we always need to consider what the caries risk assessment is and what filling we're using. I don't believe that white filling should just go for everyone, even though sometimes you will see some people do that. There's a reason why there's amalgam still on the market and there's composite on the market. You also want to see how compliant the child is, because with the amalgam, you can get it wet, but with a composite, it has to be a perfectly dry field. And if you do not always have a child that is compliant in the chair, then you may want to consider using the amalgam. That's with the idea of the fillings. Now, when you're using the front teeth, no matter what, from canine to canine, they should always be white fillings. So when a child is smiling, it's white. So going further in, if a child has a cavity and the cavity is deeper, the child may or may not complain of pain. If you take an x-ray and you see that the decay is going towards the nerve or is too close to the nerve, then the child's going to need something called a pulpotomy and a crown. The way I normally call a pulpotomy and a crown, because I do not like to talk above parents' heads, is a baby root canal and a crown. Now, when you talk about a baby root canal, at no time normally do we really go into the canals. Very rare do we ever have to do that. Normally what we do is when you have a baby tooth, only thing you're doing is just staying right by the top part of the tooth and just clearing out where the decay is and only a part of the nerve. Normally, we're not going into the canal. We're just taking out where the decay is and the top part of the nerve, and we're going to put in an antibacterial paste right where that area is. And then we're going to take a pre-fitted crown and put it over the tooth. And I tell parents, if you can think of it like a cap, that's pretty much what we're doing. Now, some parents would say, well, why do you have to put a crown on? And I explained to them, the reason why you put a crown on is because the tooth basically had decay and we had to basically gut it out, right? And anytime you take out a nerve supply pretty much out of the tooth, it's not as strong. And again, we're pretty much right now talking about the molars in the back. And children are constantly eating, biting, and chewing back there. And we want to use something that's strong enough for the children to be able to still grow, eat, chew, and not have pain, because children should not be living in pain and having to have a compromised bite or say, oh, I can't eat this or I cannot eat that. So that's why we tend to do the pulpotomy and the crown. Now, as far as, and I was going to just roughly just show you what it can look like, because I do have pictures on my phone, no faces to be shown. Now, just to show you what a silver crown can look like. I don't know if you can see that right there. That's the silver crown. It's in the back. It not really can be seen. And it's all the way back and it's somewhere where they're just chewing at. Now, also, the crown can also come in white. And there it is in white as well. There's 2 white crowns that was done back there. Now, for some parents, they would say, I don't want a silver crown. I want a white crown. Now, with the white crown, that's fine too, but I'd like parents to understand that it cannot be crimped. It's only held on by cement. So normally when you put a white crown in the back, the white crown is normally for the patient that I always tell parents that is compliant and knows how to follow the rules. That's for that child that knows that when they go to a birthday party or they go away, they know that they cannot have gummy bears. They're not going to try to chew gum. It's for that patient that would say, oh, mommy told me or daddy told me I can't eat this or I cannot eat that. Now, we are using the best cements on the market, but unlike adults normally, if they have crown work, they're conscious and they would say, oh, let me be careful not to chew on certain things. Children are children. They're still going to go in for what they want to go in for. And again, when you're talking about these molars in the back, normally some of these children are getting some of these crowns about age 5, 6, maybe 7. And these teeth are not falling out to age 11, and some children 12. But maybe by age 11, sometimes these teeth are not falling out. So with the white crowns, again, they're only held on by cement. With the silver crowns, you can crimp them and you can get more of a custom fit. Normally also with the silver crowns, I also feel like with the silver, because you can crimp them, they can be tighter. Again, with the white, it's only held on by cement. So I always tell parents, if you know your child doesn't really follow the rules, go with the silver. As far as with the front teeth, again, they come the same way. Now, with the front teeth, you can get them, same thing. If you have decay and the decay is going to the nerve, same thing they will do. They will treat the nerve, go in, put in an antibacterial paste. Now you can get a silver crown, but today's society, there's still some dentists that make it all silver, but in my practice, I do not do that. You can get a silver crown with a white facing, where it's porcelain in the front and it's silver in the back, meaning that when the child smiles, it's all white. You won't even see the silver. It's only silver behind the tooth, which I have a picture of that as well, which I will show you. So again, that's only if the decay goes to the nerve. You always want to go ahead and take that nerve out. The reason why is because you do not want the child to experience any more pain. It is the same type of pain that an adult will feel if they have decay or bacteria going to the nerve. Again, I have another photo that I can show you a before and after, just to show you what decay can look like on some of these teeth, the children that come in. If you see here, this is a child that had decay. Let me can see that. Decay all the way down. But we were able to save those teeth, and this is what the child looked like 6 months later. Again, white in the front, silver in the back. But when the child smiles, you cannot see it. Now, if we're not able to save the teeth, then we will consider an extraction. Normally, when we do an extraction, that's because you've gone beyond the filling. We've gone beyond the space of where we can no longer do a nerve treatment and put a crown on the tooth. And now we got to extract the tooth. If we extract it, what we always strongly recommend is to put in a space maintainer. The reason why you want to put in a space maintainer is because, and again, this is for the molars. You don't put space maintainers in really for the front teeth so much. It's for the molars is because the permanent molars come in at age 6. And what happens is that teeth tend to drift and they tend to move because teeth like to touch each other. And if teeth are drifting and moving, then you lose space for the permanent tooth to come in. As I was saying before, those molars in the back tend not to come in to age 11 or 12 years old. So then we can put in either a single space maintainer, or you can put in a loop, or you can even put in something on the top like a Nance, which are different types of names that you can put in, which we can do as well for the patient. Now, also another type of treatment, because we can also talk about how if you do not get your baby teeth treated, your first permanent molar comes in about age 6. And that bacteria, like Dr. Chance was talking about, can spread. So if a baby molar has decay on it and we're not treating it, it can start to spread to the permanent molar. If it spreads to the permanent molar, you're not going to necessarily always do a root canal on a 6 or 7-year-old. So then again, we're doing some type of a pulpotomy. Again, not always sometimes going into the canal, but doing some type of just the top part of the tooth, meaning just the corona part, treating that part of the nerve. So that's why it's important to treat the baby teeth, because what parents don't always realize is that children get something called a mixed dentition, meaning that you have baby teeth and you have permanent teeth in the mouth at the same time. So when you have that bacteria that's on the baby teeth will spread to the permanent teeth. So that's why it's important to either get your fillings done, which can be done in silver or white, depending on the caries risk of the patient, or they can end up with a crown, again, which can be silver or white. From my office, again, it depends on how compliant the patient is and the caries risk assessment. So if I have a child that needs 8 crowns in the back, I tend to use silver. If I have a child that may only need like 2 crowns or 1 crown, then I tend to use white, depending on how aggressive sometimes the parent is as well, how aggressive the parent can be as well. Or if I have a child that needs an extraction, then we just have to extract the tooth. Then we put in the space maintainer, so that way the teeth do not drift if it's an early extraction. And then we're talking about, and if we didn't get ahead of it ahead of time, and there's decay on the permanent teeth, then sometimes we got to do popotomies on the permanent teeth as well. And then also, if children have accidents and they end up avulsing a teeth or losing a front tooth, then sometimes you got to reimplant and then do splints and stuff like that on a front tooth. But those are more like accidents and traumas that as pediatric dentists sometimes we have to deal with. But that's about it as far as I would say as treatments that we have to do on baby teeth. So thank you.
Thank you so much, Dr. Francis. Well, you see, we've had a wealth of information shared with us this evening. And what I'll do, I'll come back and ask each panelist, just for a brief moment, just give us one kernel that you don't want your presentation to go without us remembering. So, Dr. Chance, in about a minute, get a quick wrap. What should we not forget about your presentation?
So a couple things that I definitely do not want you all to forget is, first things first, if your child has not seen a dentist since COVID or hasn't seen a dentist in the last 6 months, you need to schedule an appointment. If your child once they get their first tooth, they need to schedule an appointment. You have to make sure that we're keeping their teeth as clean as possible, brushing 2 times a day, flossing at night. They need help with brushing and flossing. I always tell parents, you're going to need to help them until you feel comfortable with them brushing your teeth and you'll be cool with it. So that's typically a long time, typically maybe like 8 or 9 years old, but they need that help because you can see some of the things that's necessary for some children in regards to what Dr. Jackson said. And then also in regards to what Dr. Francis says, it can be very involved, but it's easier if we do everything on our work on the front end, if we can. But if not, and if we do have cavities, we're always here to help.
Thank you. Good thing to remember. Dr. Jackson, would you share with us your piece?
If I had to give one point of information, I would say to be honest with the pediatric dentist when you go in. You know your child's temperament much better than they do on a given day. You know, if they're a temperamental child or a child that can be somewhat difficult, then you need to convey that to the dentist so that you're not coming into an appointment with the assumption that they're going to be cooperative and then it ends up possibly traumatizing the patient. You know, with the advances in pediatric dentistry today, there's no reason for a child to be traumatized. There's so many different ways we can get the work accomplished without them being, without harming the child's psyche, so that they don't become a dental phobic or afraid of the dentist when they're older. And just go in well versed and make up the decision that's best for your child, because ultimately you're responsible for their care.
Thank you so much. And Dr. Francis, your kernel for us from your presentation.
Yes. What I would want parents to know is that when your pediatric dentist is sharing with you different treatment ideas, to be open to it and do not fall into the peer pressure of feeling that everything has to be cosmetic, because we live in a cosmetic society, and that you really want to do what's best for your child. And let's not have to bring children back in 2 and 3 times. And, let's just do what's best for them.
Thank you so much. Very good things to remember from all 3 panelists. For a few moments, we engaged in a bit of questions. We have 1 or 2 in the chat. And first question I'd like to pose perhaps to Dr. Chance is that in your presentation, you said you should bring children early to the dentist. The question is, how early is early? I get people asking me all the time, what's the earliest time age to bring your child to the dentist? What are your thoughts on that?
So typically you want to bring them to the dentist when they get their first tooth. When it's there, when it's coming through, go ahead and bring them in. That way, a lot of it isn't necessarily just for them. I mean, it doesn't take very long to brush that single tooth, right? It's really mainly for the parent. So we can discuss with the parent, okay, this is how we progress from here. Ask them questions about certain habits that they may be forming. Are they sucking their thumb? Do they use a pacifier? Are they doing well with breathing, with eating? Just the common basic things that a child, in regards to their health, we want to take a look at everything. So once they first get their first tooth, which may be around, some kids maybe even 4 months, but for the most part, roughly about 6 months old, go ahead and bring them in. And we love to kind of talk to you as a parent, get them acclimated, and get you guys going on the right foot.
Thank you so much. Thank you for that explanation. Dr. Jackson, as an adult, sometimes I remember before my dental days, the needle looked 3 feet long to me when I walked into the office. And I'm sure for some people, for kids, it probably looks 10 feet long. So we talked about sedation and so on. I guess the question that I would want to know as a child's parent, how safe is sedation, and should I be worried or anything about sedating my child?
I mean, there are risks involved with sedation, but as pediatric dentists, every residency teaches the pediatric dental residents how to safely do sedations on pediatric patients. Every office that does sedation is required to have all the reversal medications on board. As a pediatric dentist, you have to be either advanced cardiac life support or pediatric advanced life support trained. Your staff has to be CPR certified. We run emergency drills. So we try to do it in as safe environment as possible. But again, there are risks involved. And if that's a concern that parents have, then the OR might be the best route for those particular patients.
Thank you so much for that answer. And for you, Dr. Francis, we know the constant argument, discussion about amalgam and what makes you go crazy and whatever and all these things. What are your latest thoughts on these on the resolution of the discussions on amalgam?
I'm going to tell you, I still have my amalgams in my mouth. What I know and what I've seen and what I've done in research is that a lot of the white fillings sometimes cause sensitivity and have led to a lot of root canals. And someone who's practicing and see what white fillings can look like after a while, I believe that the silver fillings are holding up. And if it's not bothering you, why are we drilling them out? And they've been around for a long time. So I would say just leave them alone. And really, it really depends on how deep your filling is, if you should be putting in a white filling or not. It's not, everything is not for everybody.
Excellent. I mean, I myself have got amalgam fillings in my mouth over 50 years. I don't think I'm more crazy than anybody else that I know, but then I might be wrong on that. Question from the audience. Dr. Chance mentioned that bacteria can be transmitted to children from a parent by sharing meals. Does this risk exist uniformly across all types of food? Is a question from the audience.
Yes, I mean, it's not necessarily the specific type of food. It's just if your saliva is in their mouth in any way, then that's basically what I mean. So if, let's say, your child has a pacifier and drops it, and then I've seen it where you pick it up and put it in your mouth before giving it to your child. That's what I'm talking about. Anytime your saliva is in their mouth, kissing on the lips, anything like that, then you're transferring that same bacteria.
Yeah. So same as a matter of contamination and not the food or whatever else you're putting in the mouth.
Correct.
Excellent. All right. I think we have perhaps time for one more question, and either Dr. Jackson or Dr. Francis could approach this if you like. How do you break the habit of thumb sucking or tongue sucking in children? How do you address it?
Do you want to take it, Dr. Jackson?
Go ahead, Tanisha, you got it.
I was going to say, it depends really on the patient and the parents, because you have some parents that are very aggressive and say they want their child to stop, and they're willing to put the Band-Aid on there as a reminder, but really the patient has to be willing and want to stop. And then you have some children that are just determined to keep sucking and they're not going to. So there's even something that you can buy that's even a thumb guard, where you can put it on the hand and it's a full guard, so that way the child cannot take it off and they cannot put the thumb in the mouth. But
Thank you.
Parent and child to be working together.
And I tell a lot of parents too that most often kids don't really want to stop until they see other peers not sucking their thumb. So when they start school, especially, and they see their peers aren't, they tend to dramatically decrease the amount of thumb sucking that they do. That being said, parents will always say they never suck their thumb at school, but as soon as they get in the car, it goes in their mouth. So that's when the parental involvement really becomes a key factor.
Thank you so much for that. This has been a wonderful discussion, panelists. I've enjoyed it. I'm sure as many of our viewers have. So I want to thank you all for these wonderful presentations. I also want to thank those on virtual line and who joined us and joined for this program. Thank you very much for joining us. And at this time, I'd like to turn back over to our Surgeon General, Dr. Jeffrey Sterling, for final remarks.
Well, thank you all. That was actually quite interesting. It makes me want to engage. But then again, I'm crazy that way. I enjoy the maintenance of body and mind. Let's bring the panelists back up. I actually have a question for you in the spirit of what it is we do here. So given that the Surgeon General Initiative is about health prevention and promotion, one of the things that I'd like for you collectively to opine on is what you do to empower families at home to deal with the dental experience. I'm a little surprised and tickled that that wasn't given a lot of conversation, but I mean, we all know that kids are somewhat afraid of the dental experience. But there are things that we can do for kids at home. And you mentioned the experience with the first tooth where you're treating both the child and the parent, which I think is brilliant. But let's just get your thoughts on what it is you can have parents do at home to teach them how to brush and floss and to enjoy the entire dental experience. So when they see you, they don't get the white coat syndrome and get afraid and scream and yell and become a problem child, literally and figuratively, for you.
Well, I think the first thing that parents need to do is not convey their fears of the dentist on their children. You know, a lot of times a parent will bring a child into the office and they're in the corner the entire time or looking away, and the child is fine, and they sit up and look at the parent, or the parent's constantly saying, "Are you okay? You're okay." It gives them the sense that something should be wrong. So that would be my advice: is don't put your fears on your children.
And also to support what Dr. Jackson is saying, sometimes what parents do, they threaten their kids as a punishment to go to the dentist, right? Say that to them. Like, or they'll say they're going to yank your tooth out, you know, when we're talking to them about treatment plans on the side. So what I normally try to tell parents as well is to make this a pleasant experience, is that when they're brushing their teeth at home, to sing songs with them and to use my name in a positive way and to not use it as a threat. And also when the children are young, I tell the parents that the children always win in the morning, that there's no fighting in the morning by brushing the teeth. The parents win at night, but the children win in the morning. So that way everybody starts off with a good day. But at nighttime is where we use my name. That's when we talk about it.
Very good. And go ahead, Dr. Chance. I see you ready to go.
Oh no, I was saying, just kind of piggybacking on what they were saying. Those are amazing recommendations. And you know, nowadays there's so much technology now that you can use to help combat some of these fears, right? So there's songs, you know, Gracie's Corner, there's Jules. It's like there's a lot of different, you know, animated or what have you, shows that kids can watch, and they can see that you can have fun while being at the dentist, right? And also you combine that with some of the technologies that we're doing at the dental office, like go on your dentist's website and take a look at the pictures of the office that you're about to go to, right? And show your children the pictures of the staff members on the website. You know, show them, get them acclimated. Use, like Dr. Francis said, use the staff member's name, the dentist's name, in common verbiage, so then they can feel like, okay, they're going to see a friend. They're going to see a friend of the parent versus going to see someone that is this all, you know, scary person that, and they don't have to be fearful. A lot of times you see kids of parents who do that, and they come in empowered. They come in confident. They come in not knowing what it is they need to fear, because they've never been told there is something to fear. So just like what they said, don't put your fears on the kids.
Very good, very good. So in other words, and this has actually happened, kids don't use the dentist as a boogeyman, as a form of punishment. If you do bad, I'll take you to the dentist. That's not a good look. That actually
Not
happened.
good at all.
Yeah, not good. And I'd actually also suggest that some folks have conversations with the pediatricians and ask for some sugar-free lollipops that I don't want to get distracted, but you know where I'm going. Again, I want to thank you all. You've been great, Dr. Chance, Francis, Jackson, as always. Brother Dr. Bell, you've been a fantastic panel. And I hope that you got something out of this. And we are always available for you. This webinar will be available on Sphinx TV on YouTube. And of course, at the Alpha Phi Alpha Facebook site. Feel free to like, share, and subscribe. We will be back 2 weeks from this evening talking about mental health. And we'll be talking about suicide prevention. So join us back then, and we always welcome your suggestions for webinars that we can be offering. Thanks again to everyone, the board and General President Lonzer for providing us with this forum, and I hope everyone has a wonderful end of summer. Thank you and good night.
Thank you.
Thank you.
Good night.